Chapter 21, Impulse Control Disorders. So the development of a psychiatric illness can be devastating to the person affected and to significant others. Disorders such as autism and schizophrenia can alter the entire direction of a person's life, yet it is usually evident that there is a psychiatric basis to the disorder. Comparatively, people with impulse control disorders may seem like children whose parents cannot control them, or adults who simply do not choose to control their behavior. Disruptive impulse control and conduct disorders are characterized by aggressive behaviors and emotions. Problems relating to others in socially acceptable ways result in a lack of healthy relationships, leaving the individual isolated and the family devastated. The behaviors related to these disorders can have severe criminal consequences and long-lasting negative personal impacts. Recognizing and treating aggressive and impulse behaviors while a person is young can prevent further problems and avoid interactions with the criminal justice system. Unfortunately, stigma and misconceptions around mental illness may cause individuals and their families to conceal these conditions. Concealment can limit help seeking and professional care, preventing a timely intervention. Unfortunately, without professional care, many young people end up interfacing with the criminal justice system where treatment may or may not take place. According to the American Psychiatric Association, or APA, major disorders considered under this umbrella include oppositional defiant disorder, conduct disorder, and intermittent explosive disorder. Now, there are two other disorders included in the disruptive impulse control and conduct disorders section of the DSM-5, and these are pyromania and kleptomania. Now, these conditions will be very briefly addressed following the other three disorders. The disorders discussed in this chapter are characterized by aggressive behavior and aggressive emotions. There's some examples I'm going to give you of impulsivity, such as blurting out answers before a question is finished, the inability to take turns, or frequently interrupting others while they're talking. So trust is often an issue because they may not have ever had a trusting relationship. Trust is so important because it promotes feelings of security, and for the nurse, it establishes trust for the therapeutic use of self. Now, it is important for early intervention and treatment in order to aid in establishing a healthy relationship and prevent legal difficulties. Now, as we discuss these disorders, it is important to understand the difference between behaviors as defined by the APA. Emotional behavior includes anger and are linked to current and future mood disorders and anxiety. Behavioral includes defiance and spiteful behaviors, including revenge seeking, and these are predictive of future conduct disorders and delinquency. Okay, the first one is oppositional defiant disorder, or ODD. Children and adolescents are oppositional at times, but it becomes a concern when the frequency begins to interfere in the family as well as social and academic areas. So we know this. All children talk back. They argue, they disobey, especially if they're hungry and especially if they're stressed out. But it is important to ascertain the frequency and the tenacity of any oppositional behavior to see if it's within the normal range of behavior or if it is symptomatic of other types of behavior. So ODD is a frequent and persistent pattern of anger, hostility, irritable mood, disobedience, and defiant behaviors. Most often the behaviors are directed at the caregivers and at their authority figures. These people are consistently negative, disobedient, argumentative, and hostile. Now, page 392 gives you the DSM-5 criteria for ODD. Now, ODD affects both emotions, so like anger and irritation, but also behaviors, so that's that argumentativeness, the defiance. Children and adults with ODD show a preference for large rewards, and they pay little attention to increasing penalties. These people do not back down, even when they're faced with these penalties. ODD may be a precursor to a conduct disorder, which we will talk about momentarily. So the epidemiology, ODD is typically diagnosed around age 8, but can be seen as early as 3 years old, but usually not older than early adolescence. ODD occurs 3 times more often in males than in females. Now, as far as comorbidities, the most common is ADHD. That occurs in about 40% of children with ODD, but they also can experience anxiety and depression. Now, if the symptoms are severe, then a diagnosis of disruptive mood dysregulation disorder needs to be given instead of ODD. As far as risk factors, there is a genetic component with a family history of mental illness. And neurobiologically, the gray matter in people with ODD is less dense in the left prefrontal cortex area, and that area is responsible for impulse control and self-regulation. Now, smaller brain structures and lower brain activity suggest impaired control over their emotional behavior. Physiologically, they tend to have reduced cortisol reactivity to stress. They experience sympathetic nervous system hyporeactivity to incentives and a low basal heart rate during times of sensation seeking. These states may make these people prone to sensation-seeking behavior, such as defying authority, breaking rules, and abusing substances. Now, I said they can have a low basal heart rate, but they may not always have that. Cognitively, negative symptoms are acquired. These negative symptoms stem from caregivers and those in authority over them. Environmental, family distress in the home, conflict between the mother and father, abuse of the child, and inconsistent punishment may all contribute to ODD. Now, often, their behavior requires an active response. Redirecting their expression of feelings into non-destructive, age-appropriate behaviors can help diffuse the situation. So using physical activity with children with ODD can be key. Take them for a walk, go on a bike ride, let them swim, because this helps the child learn to modulate the expression of feelings and exert self-control. Treatment for ODD, there's really not any pharmacological treatments out there, but the child may benefit from psychotherapy with an emphasis on anger management. So next we will move into conduct disorders. A conduct disorder is characterized by aggressive behaviors that often include hostility and physical violence toward others. The hallmark of a conduct disorder is that aggressive physical behavior, and they violate the rights of others. Now, conduct disorder is a persistent pattern of behavior in which the rights of others are violated and societal norms or rules are completely disregarded. People with this disorder initiate physical fights, and they do engage in bullying. They may be suspended from school throughout the academic year because of this. Coercion into an activity against another's will, including sexual activity, is characteristic of this disorder. And there is a significant negative impact on the patient's ability to function socially, academically, and professionally. The ability to follow rules, show respect, and emphasize with others is very difficult. Now, childhood onset occurs before age 10, and it's primarily in males. Adolescent onset occurs after age 10, and it affects males and females pretty much equally. Now, there is a subset of people with conduct disorder that exhibit the especially dangerous qualities of being callous and unemotional. Callousness is characterized by a lack of empathy and being unconcerned about the feelings of others. Expression of guilt is absent, except when the individual is facing punishment. School and family obligations are unimportant to these people. And callousness may be a predictor for future antisocial personality disorder in adults. Unemotional traits include a shallow unexpressive superficial affect. Page 395 gives you the DSM-5 criteria for conduct disorders. Now, clinical manifestations will show as aggression toward people and animals, destruction of property, lying, theft, and a violation of rules. Comorbidities, ADHD, and ODD are common diagnoses, and these patients usually have the more severe and negative outcomes with them. Now, risk factors. Genetically, there does seem to be a genetic component if a parent or sibling has been diagnosed with ODD. However, there is a controversy about whether it is related to genetics or a hostile environment. Neurobiologically, studies have revealed reduced gray matter in the brain and more folds in the cortical insula, as well as diminished blood flow to the region that is associated with their emotional responses. Environmental, we've already talked about ACEs, and you can see examples of ACEs here on page 395. These include things such as harsh discipline with inconsistent parenting or growing up in an institutional environment. Now, complications, academic failure, school suspension, school dropouts, juvenile delinquency, substance abuse, and juvenile court involvement can all be complications. Now, when you're working with these patients, it may be helpful to create a behavioral contract to identify the expected behaviors as well as the consequences. Signing the contract means the patient assumes responsibility for their behavior, but when you make that contract, make sure you list the rules, list rewards, and list any consequences. Now, these children are often prescribed antipsychotic medications to help manage the violent behavior. The main difference between ODD and CD is that in conduct disorders, they frequently will violate the rights of others. Intermittent explosive disorder is characterized by disproportionate anger and aggression, which can lead to frequent explosions. The aggression can be verbal or physical and is targeted toward other people, animals, property, and even oneself. The explosions occur for 30 minutes or less in duration, 2 times a week for 3 months, or 3 behavioral outbursts destroying property in 12 months. Anything can trigger the aggressive reaction to the situation. A man may be unable to locate his favorite video game and impulsively punches his fist through a pane of glass. He may tear his room apart, break furniture, or damage costly property. As the rage continues, he may attack anyone who intervenes and will often cause injury. The explosive anger may occur during a competitive sport, such as lashing out at an opposing baseball fan when his team loses. A pattern that commonly emerges is going from rage to remorse. So, clinical manifestations. Explosive episodes may be associated with feelings of increased energy and irritability, yelling, throwing a tantrum, assault against people, animals, and property, expression of racing thoughts, feelings of depression, or fatigue after outburst. Epidemiology. Onset is usually late childhood or adolescence, with rare diagnosis after the age of 40. Comorbidities, depression, anxiety, substance use disorders, antisocial disorder, borderline personality disorder, ADHD, increased risk for suicide, hypertension, diabetes, heart disease, and ulcers. Risk factors, biological. Higher inflammatory markers during infection, which can facilitate aggression. They may have higher levels of testosterone. Loss of neurons and abnormalities in serotonin levels have also been found in individuals diagnosed with intermittent explosive disorder. Environmental, those ACEs, so childhood trauma and violence, especially physical and sexual abuse. Complications Intermittent explosive disorder can lead to problems with interpersonal relationships, occupational relationships, but it can also lead to legal entanglements. Now, Table 21.1 on page 397 gives an overview of all impulse control disorders. So some other disorders we'll talk about very briefly. Are kleptomania and pyromania. Now, these two disorders are not impulse control disorders, but they are closely related, so that is why they're included here. Now, kleptomania is a condition in which a person experiences a consistent impulse to steal items they do not need. They experience a level of tension prior to the theft and then relief or gratification once the item is stolen. Kleptomania is associated with other impulse control disorders and impulse control related problems, such as impulse buying. It is also associated with mood disorders such as major depressive disorder, anxiety disorders, and eating disorders, particularly bulimia nervosa, but also it can be associated with personality disorders. Again, they will steal things they do not need. For example, they may steal baby clothes, but they do not have a baby. Now, pyromania, it is a rare disorder that is characterized by the intentional and repeated setting of fires. There is a deep fascination with fire and related paraphernalia. These people experience feelings of pleasure, gratification, or release of inner tension once the fire is set. It is more common in males, especially those with learning disabilities and poor social skills. So Jeff, 15, is described by his parents as rebellious to the point that he is really impossible to control, no matter what approach we try. He's been like this from the time he was very small. We are at our wits' end. In fact, Jeff's parents are not the only ones concerned. His history shows that from the beginning, in kindergarten, teachers and authorities have documented Jeff as spiteful, vindictive, and physically aggressive. Jeff, who is diagnosed with oppositional defiant disorder, is taken to the principal's office after assaulting and injuring another student. Which comment is this adolescent most likely to make? D. So what if that kid was hurt? I should have beaten him more. Because with ODD, they show no signs of guilt or remorse. Now, application of the nursing process. Assessment. General assessment includes careful interviewing of both the child and the family members to determine symptoms and identify the disorder. You can see the assessment guidelines for each one here on page 397. Be familiar. Now, a suicidal risk. The risk is high in these disorders due to their impulsive nature. Assessment tools on page 398. You can look at, figure 21.1 for examples of tools used for ODD and conduct disorder. A score of 2 or higher is indicative of a problem and further assessment will be necessary. Nursing diagnoses, they could include things like impaired impulse control, risk for suicide, aggressive behavior, and risk for violence. Your outcome should be patient-centered and it needs to be a collaborative effort. Implementation. Psychosocial. They may need trauma-informed care as well as outpatient treatment that includes individual, group, and family therapy. Teamwork and safety is important. Be aware of power struggles between staff and the patient because this can increase aggressive behaviors. Body language and tone of voice by staff are major contributors to this. Seclusion and restraint need to be used as a last resort. You can see box 21.1 on page 400. Here, for other techniques to manage disruptive behavior, here's where that behavioral contract is. help teaching and promotion, family support is needed to create a structured and consistent environment. If the home is abusive or explosive, other options for placement may be necessary. In evaluation, you need to work toward the ability, or the patient needs to work toward the ability to self-regulate and control their behaviors. Biological treatment modalities. There are no approved medications to treat these disorders, but medications are used to treat the symptoms of aggression, anger, as well as outbursts. As you can see, there are several examples of medications listed on this slide, but we need to avoid benzodiazepines because these have a similar effect to alcohol, and that further reduces the inhibition in their self-control. Now, there are a lot of psychological treatment modalities. CBT, cognitive behavioral therapy, I'm not going to get into because we've already talked about that, but that is huge here. But there's also a trauma-focused CBT therapy that's specifically for children who have experienced a trauma. Psychodynamic psychotherapy aids the patient in understanding and uncovering underlying issues and thought processes related to the anger and their rage. Dialectical behavioral therapy, you will see this again, but it aids in mindfulness, emotional regulation, distress tolerance, and personal effectiveness. Parent-child interaction therapy gives parents strategies to help reduce problematic behavior in the child. Parent management training is helpful for children aged 2 to 14 years old because it helps parents learn effective discipline strategies and how to promote positive behavior. Social skills training. Since individuals have difficulty with social relationships and understanding the feelings and emotions of others, this training is important and it's performed in a group setting. And finally, multisystemic therapy. It is the most extensive form of therapy, and therapists are available 24/7 and they go wherever the child may be. Harmful activities or idleness are going to be replaced with healthy activities. So a nurse is assisting the guardians of a school-aged child who has oppositional defiant disorder in identifying strategies to promote positive behavior. Which of the following strategies should the nurse recommend? Select all that apply. C, D, and E. Develop a reward system for acceptable behavior. Encourage the child to participate in school sports, and be consistent when addressing unacceptable behavior.